Session 209, Common Presentations in Primary Care. Don't always look for the zebra. Just a couple of announcements before we start. Please remember to turn off all your electronic devices to silent mode. If you're attending with a young child, please use discretion. We ask that you try not to disrupt another's learning experience. Please join us for the SIG showcase from 6 p.m. to 7:30 p.m. tonight in Regency 5. We encourage you to visit and learn more about SIGs. Posters on the move are available in Regency 5 from 7 a.m. to 7 p.m. Presenters will be available for questions from 6 p.m. to 7 p.m. Join us Saturday at 6:30 a.m. for a Zumba fundraiser. Sign up now at the registration desk. This session is using audience response technology. At the end of the session, please remember to return your keypad. Dr. Garzon is a teaching professor of nursing at the University of Missouri, St. Louis, and an adjunct instructor of child psychiatry at the Washington University School of Medicine. Dawn has over 20 years of experience as a pediatric nurse practitioner in primary care, urgent and convenient care, and she is a seasoned nurse practitioner educator. She is a certified pediatric mental health specialist. She holds a bachelor's through doctoral degrees in nursing and completed an NIH-funded postdoctoral fellowship that culminated in her earning a Master of Psychiatric Epidemiology. She has extensive publication and speaking experience with focus in areas of pediatric mental health and pediatric primary care. Please join me in welcoming Dr. Dawn Garzon.
So thanks for coming after lunch. In the interest of full disclosure, yes, I'm Irish, and no, I don't have green on. But when you spend your life looking like you should be on a Lucky Charms box, then wearing green on St. Patrick's Day isn't as critical. So yes, I am Irish, for those of you that were possibly confused by that. So today we're going to talk about common pediatric primary care presentations. I would love to tell you that I have all these great disclosures to make. The main one is I will be talking about some non-FDA approved approaches. So the learning objectives, I'm going to kind of scroll through, but this talk is not advanced. This is about what we do in our bread and butter as primary care providers. So this is not a discussion about the rare diseases that can masquerade as common presentations. What it is because this is what we do all day, every day, I confess that there are times I go on autopilot, right? You find yourself having that same discussion time and time again. You have that same approach time and time again. And it's often the things that we do all day, every day, that we don't realize that what we're doing may not be what the guidelines say we should be doing. So today is a very basic, day in, day out, nothing glamorous approach to what do the clinical practice guidelines say about how we're supposed to approach these common presentations in primary care. So first one is ear pain, right? Isn't that the reason why everybody comes in? I'm here because we're leaving for Florida next week on vacation, and I want to make sure they don't have an ear infection. Or he kept me up all night last night, and he's pulling at his ear, and I'm pretty sure he has an ear infection. And that's why they came in. So why is it a big deal that we stop and we think about how we're managing otitis media? Because it's one of the leading reasons for overprescribing antibiotics. And this can have significant sequelae for our kids and is a leading cause of pediatric drug resistance, which everybody in this room understands is a massive public health problem. So when kids come in with complaint of pain, yes, it can be acute otitis media, but it may be an ear effusion. It could just be good old-fashioned eustachian tube dysfunction that we all get when we have a head cold and we're sitting there and we're like, ow, my ear hurts. And it lasts for a couple of seconds and then it moves on. They could have temporomandibular joint dysfunction. And how many of you guys are starting to see these kids with these horrible teeth coming in because folks aren't able to get that routine dental care? I had a kid that came in, an autistic kid about 2 weeks ago, had a complaint of ear pain, had bloody gums and probably 4 or 5 cavities. But he had such a bad dental visit that mom stopped taking him to the dentist about 5 years ago. So his ear pain was actually an abscessed tooth. So how do we know if someone actually has a true ear infection? And the diagnostic criteria is all about having a bulging TM and the presence of pus in the middle ear chamber. When you just have fluid in the middle ear chamber and don't show those active signs of infection, that's otitis media with effusion. Those are our non-suppurative otitis media cases. And about 90% of kids, before they get to school age, are gonna have an AOME. And many get as many as 4 a year. So let's start with the responders, and unfortunately we don't have enough for everyone in the room, so hopefully you can play nice with your neighbors. I'm gonna go ahead and give you a key and you can go ahead and get started. What is this? This was acute otitis media. If you look, you've got the presence of pus, and if you look also up at that upper margin, you've got a nice bulging TM. See where that long process comes down and the TM is bulging out around it? It's that combination of pus and the bulging TM that makes your diagnosis. What about this one? Go ahead and input now. So, we had a technical glitch, most likely caused by the redhead on the stage, but this is an otitis media with effusion. Now, I always love these pictures that are open available on open source. You know this was an adult, right? Because if they're 2 and they're going, no! When you're examining them and their faces are red, their eardrums are red too, and I think that's why it gets a lot more confusing for those of us who are looking at the ears, because you get that kid with that red ear, but you can see that it's not full, it's in a neutral or retracted position, and there is no pus that's present in that middle ear. So yeah, wouldn't it be great? Those are the teenagers that walk in that look like that. What about this one? Go ahead and play. I almost feel like I should be humming the Jeopardy tune, but I can't carry a tune, so I'm gonna be really nice and hold off on that for you. If you look carefully, look up at 12 o'clock. Look at that short process on that TM. See how it looks like an elbow or a heel sticking out? That's a retracted TM. That's somebody where instead of that TM sitting flat against the bones of the middle ear, it's being sucked back on those bones of the middle ear. And this is very, very common with upper respiratory tract infections. So the most important factor is, we can all look in the ear and hopefully we can see it because they don't have tiny little canals full of flaky wax that are impossible to get out. And they're at least being moderately compliant that we can see. We go, oh gosh, this doesn't look right, right? That's the first step always. So now we have to figure out, is this an otitis media, which may or may not merit antimicrobial treatment, or is this an effusion? So according to the clinical practice guidelines, the key feature is that bulging TM. And that's why we're supposed to use pneumatic otoscopy. So how many of you guys, when you're in your programs, did your instructor make you put that little air insufflator on and make you play with it? And how many of you still play with it in your practice? Okay, about half the people that had their hands up put their hands down. What that does, if you get a good seal, is allows you the ability to see if there's movement there to get a feel, is this truly a bulging TM versus a neutral TM versus a retracted one? And if you see a retraction, that is not associated with acute otitis media. And they hurt like stink. This is not about symptoms. This is about what the pathology is. So the flip side of it is, many of us do tympanograms, right? And we do tympanograms, and we get a tympanogram, which, oh, by the way, you're not supposed to do population screening. So when you get your early childhood programs and they go into an elementary school and they screen 300 children with tympanograms, that's not according to the guidelines. Because you're going to get a lot of false positives. We've all been there, right? The parent comes in, oh my gosh, it's flat, they can't hear, and the school said, and oh my gosh. And the kids, having a good day, and they're in the office and they look fine and their ears look fine, and the mom's freaked out and the kids freaked out, and it was because maybe they weren't compliant during the test and they didn't get a good seal. What the tympanogram can do is help determine if there is fluid behind the TM. What it can't do is distinguish whether or not it's purulent or not. Almost always, ear infections happen with colds. And we know that, right? The kid gets the cold, they've had a runny nose a couple of days, all of a sudden they're up all night, and parents come in, and that's the most likely scenario that we encounter. But that eustachian tube dysfunction is uncomfortable. Your ear's cracking and popping, and the pressure is there. And you're going to mess with I'm 48 years old. I mess with my ear when that happens. And I know what's going on, and I have words to go, oh, it sounds like I got Rice Krispies in my ear. I'm not a 2-year-old that's just going, this is not right. This hurts. I'm mad. So how do we treat acute otitis media? If we make the determination that it is, in fact, an active infection, how do we treat it? The question becomes, who gets antibiotics? So this is the guidelines. This is the ideal. This is what we should be striving for. And we're going to talk about maybe how we can get there. If you have a child who's under 6 months of age and you think they have an otitis, you should treat them with antibiotics. If they're over 6 months and they have severe pain, that kid who's sitting in your office crying and screaming and has a fever associated with it, they get antibiotics. If it's both sides, not unilateral, but bilateral, and they're between 6 and 23 months of age, if they have no otalgia for 48 hours, and they have a higher temperature. So these kids that are coming in for their well checks and they're happy and they're not complaining and they're 4 and 5 years of age, and you look at their ear and their ear doesn't look good, they don't meet any of those criteria for automatic antibiotics. They fall into that category that we should consider observation for them. So any child that's over 2 years of age who has acute symptoms and isn't severe and crying and miserable with it, or has a high fever, then we can give them 48 to 72 hours to see if it gets better on their own. Now, we all know that. Why do we not do that? Because parents leave really mad, right? Because they're like, well, I'm here because I'm here for an antibiotic, and they come in with the brand name that they expect. So then what do we do as far as approaches to handle that? So if you've got a kid that you can't see their ear, and I'm going to tell you 22 years in, there are still kids that if I had 2 hands, a roadmap, and a federal consultant, I am not seeing their TM. It is not happening, okay? Either tiny canal, uncooperative kid, or they've got earwax the size of a VW box that we cannot get out. I can't see that TM. If they have no pain, if what I can see, and they have no pain, and they have no high fever, then I can use an observation. And what's the problem with calling it? If you can't see it, you can't call it. If you can't see that whole TM, if you're just getting that little itty-bitty rainbow across the top, that's not enough to see what's really going on, because where's the pus going to be? With gravity, on the bottom side of the TM. So if you can't see it and they're not running high fever and they're not having extreme pain, then you can go ahead and use observation. What do we use? What do the guidelines say we're supposed to use? Amoxicillin, 80 to 90 mg per kg for 10 days if they're under 2, which is what we all do, right? It's drilled into our heads from our first pharmacology course, right? 80 to 90 milligrams per kilogram of amoxicillin for 10 days. Except if they are over the age of 2, you're okay treating them for 7 days. And if they're over the age of 7, you can treat them for 5 to 7 days. And you say, why is that a big deal? Because if you don't have to give them 10 days of treatment, that's an additional 3 days that you can have an allergic reaction, that you can get C. diff, that you can have resistance buildup. The alternate to amoxicillin is amoxicillin and clavulanic acid. It is not all the cephalosporins that we automatically jump to. Our second line is amox-clav. We go, and let me go back for a second. That's especially important if they've had antibiotic use within 30 days, or if they have a concurrent conjunctivitis. And we're going to talk about red eyes in a little bit. The cephalosporins come into play with penicillin allergy. Okay? So those are going to come in if we're penicillin allergic, or if they've already failed amox-clav. And looking at this list, what do we all use typically? The first one, right? Because of taste. Because how many of us enjoy bringing a child in for 1 to 3 days treatments of ceftriaxone, right? That doesn't fly particularly well. And then you add in clindamycin, which anybody who can get 10 days of clindamycin in a 2-year-old is a much better woman than me. I don't care, you could banana flavor it, you could bubblegum flavor it, you could offer up offerings to whoever you need to. The odds that you're going to get 7 to 10 days of clindamycin in a 2-year-old are slim and none. If any of you guys know how to do it, please let me know. So what wasn't on that list? What's the one that wasn't on that list that everybody comes in asking for? Azithromycin. So the guidelines clearly state that azithromycin is only an acceptable alternative if there's a type 1 anaphylactic reaction to amoxicillin. Remember that azithromycin is a static drug, and all of the macrolides have higher resistance profiles associated with them. You should not be routinely using azithromycin as an alternative for the treatment of otitis media. That's not me, that's the clinical practice guidelines. And then what do? The kid's miserable, and that's really why we treat it. So give them ibuprofen, give them acetaminophen, make them comfortable. For those of you that haven't tried to write for benzocaine drops since last July, what happened last summer? FDA pulled them off the market. Not because they were dangerous, but because they never found the clinical trials that showed safety and efficacy in pediatrics. They are no longer commercially available. So those abiotic drops that people have hiding in their cabinets, once they're done with expiration, they're not replaceable. We do not do routine follow-up for ears. So this, come back in 2 weeks, 3 weeks, Tuesday if you have blue underwear on, whatever the variety is, are not guideline appropriate. So then comes the next question that we always get. Oh my gosh, he's had 2 ear infections since Thanksgiving. Do we need to get tubes, right? We had to use amoxicillin, and it doesn't work for him anymore, and now we have to use all these drugs, and does he need tubes? So if you have a kid with an effusion, you want to give them 3 months to see if they'll spontaneously clear it up on their own. If you send them off to a specialist and they don't have any fluid in their ear, pussy or otherwise, at the time of evaluation, they're not supposed to be scheduled if they've resolved. They're supposed to say, if it occurs again, give us a call. Because what do we know? Like, you guys are still dealing, like, is this the worst RSV season ever, right? So RSV has just gone on and on and on and on. And now flu's come, and we've got a little metapneumovirus thrown in there, and we've got some rhinovirus in there. And if we could just get the weather to be nice so that we could go outside and stop breathing on each other all the time, this too will pass. And then maybe they'll be a little bit older, and their eustachian tubes will be a little bit bigger, and we'll buy them a little more time. So who are the kids that we worry about? Those that have recurrent otitis media, defined as 3 or more episodes in 6 months, or 4 or more separate incidences in the past 12 months, with at least 1 in the past 6 months, if there is a middle ear effusion at the time of evaluation. And if they do have tubes, you know that old thing of, oh my gosh, plug their ears and put a cap, and no, you don't have to do anything special for kids with tympanostomy tubes relative to water. They can go and they can swim, they can do whatever, they don't need the plugs, they don't need the caps, they don't need all of that. Okay, so you see a 5-year-old who comes in with tympanostomy tubes. He's got clear drainage coming from behind the TM. What's your best approach? You've got oral amoxicillin, 80 mg per kg at 7 days. A topical antibiotic steroid combination like Cipro with dexamethasone. Topical and oral as above, or you do watchful waiting. And you can go ahead and, okay. So the guidelines say, if you've got a kid with tubes and you have clear fluid coming, you want to treat them with topical antibiotics because the tubes are doing what they're supposed to be doing. So we've got this fluid coming out. We want to prevent it from becoming infected. So the guidelines say we're supposed to go ahead and just treat it with topical antibiotics at this time. So the kids that have fluid behind their ear, who are the ones we need to worry about? And these are the ones that we always worry about, right? Those who are at risk for speech and language pathology, or those that have craniofacial abnormalities that predispose them to having higher issues. Or you take a child maybe that has a visual impairment who is much more dependent upon their hearing. And so for kids in those high-risk groups, at the time that they have that effusion diagnosed, we're going to go ahead and continue to monitor them at frequent intervals to see if they clear. If they have bilateral effusions or this high-risk group doesn't clear in 3 months, they're the ones that we want to send off to ENT for potential tympanostomy tube placement. If you have a healthy child who comes in with a middle ear effusion, then you're just going to have watchful waiting. Bring them in every 3 months, take a look at them. As long as they seem to be hearing okay, life is good, we don't have to do lots of additional screening. Systemic antibiotics are not desiccants. There is no reason to give someone an antibiotic if they don't have an active infection. It's not going to dry up the fluid. The antihistamines, the decongestants, the nasal steroids, all of these others don't work to open up those eustachian tubes. They don't work. So there's no need to place kids on these medications. If they're high risk, or if their effusion persists more than 3 months, Then you can go ahead and evaluate their hearing. And if they're hearing okay, then we can reevaluate them. It's when the effusion doesn't clear or when the hearing goes bad that the red flags go up and that they need additional evaluation and referral. What surgery do we do? It depends on the age of the kid. So the guidelines say if they're under the age of 4, all you need to do is put the tubes in. But if they're over the age of 4, not only do you do a tympanostomy, but you do an adenoidectomy at the same time. But what's the peak time for ear infections? 6 to 18 months. We don't get a lot of kids with recurrent ears after their 4th birthday. But those kids, according to the guidelines, benefit from the addition of an adenoidectomy. So when I come in, crazy redhead that I am, and you tell me that my child has an ear infection, but it's not bothering him, and that he does not need antibiotics today, what do you tell me? Well, 70% to 75% of your acute infections are going to spontaneously resolve no matter what you do to them. Because they're going to yawn, they're going to cough, they're going to sneeze, and that eustachian tube is going to open up and it's going to drain. We also know that the majority of the times that happens within 24 to 48 hours of their acute symptoms. And the parents generally don't care about the fluid in their ear. They care about the fact that their kid is miserable and is screaming, crying, keeping them up at night. That's what they care about. They care about the comfort of their child, not the differentiation between acute versus non-suppurative. We're going to say, look, we don't do routine follow-up on this ear infection, but if he's got fluid, I want to see him back in about 3 months and let's see if it's gone. And we can say, kids do this almost universally. This happens. This is almost a normal part of being a child at some point or another to find fluid behind that ear. We know that secondhand smoke is ridiculously irritating to the respiratory tract, and it can cause additional irritation to those eustachian tubes and therefore affect that middle ear's ability to drain. And so cautioning against secondhand smoke. And we've all been there. That's a hard one because the parents come in and they go, well, we don't smoke. We smoke outside. And you're in there and your eyes are watering because of the smoke that's on them. And I'll say, look, I'm not here to bust your chops about this. I don't want you smoking around your child, but I know you're smoking because it's on your skin, it's in your hair, it's on your clothing. So I applaud you for taking the step of going outside, but don't believe that that protects your child. Don't believe that that protects your child from the risks of the exposure to the smoke. We want our moms to breastfeed for at least 6 months, and that's very effective in preventing ear infections. Flu vaccines can be very helpful as well. And then the other side of it is, we're supposed to give them pacifiers in the first year of life, but we all know that 3-year-old kid who has to take the pacifier out and has the bottle in one hand. Once you use that bottle and pacifier after their first birthday, it starts dramatically increasing the incidence of effusion in the middle ear because of the way that they're all the time and can cause backup. So something as simple as getting rid of the bink for that 3-year-old may help solve the problem. Red eyes. So you have a kid who comes in and they've got bacterial conjunctivitis and they have an otitis at the same time. You need to treat them with both eye drops and systemic antibiotics. Beep, beep. Oh, it didn't work. Again, I would love to tell you that's this thing. I'm pretty sure it's me. All right, so most of you know that that's false. So stop for a second and say, why do we treat kids with pink eye? Because we see them all the time, right? It's always the baby that does this and then does this, right? And they got the green and it's just coming. And the mom's using her shirt, and it's stressing her out. And the kid goes like this, and then they rub their eye, and they give themselves pink eye. Why are we treating the pink eye? The majority of the time we're doing it because daycare says they can't go to school unless we've treated them. So ask yourself why you're treating this. Do you really think this is GC or chlamydia? Do you really think this is H-flu? Or do you really know that the kinder care door guard is going to keep this child out and it's going to keep mom away from work if we don't treat it? Most cases of bacterial conjunctivitis are self-limiting. You don't do anything to them, they will eventually disappear. So we treat them for comfort and we treat them to get back in school. And kids get more pink eye because although everybody on the planet picks their nose, kids are a little bit more vigorous about it and they're much more likely to touch their eyes when they're done with it. All right, I recognize that this is a little bit loaded and that every single state has different rules and regs about school attendance, but assuming that all states have the same rules, which they don't. Conjunctivitis is a reason for exclusion until they've had 24 hours worth of treatment. Okay. See, it really was my error. Okay. The guidelines say once you initiate treatment, they're okay to go back to school. So the problem is that in order to do that, you have to see them, you have to evaluate them, you have to say that that's what it is. And how many of you guys, by show of hands, see every kid with conjunctivitis in your office? Like a spattering, right? The majority of us are like, you have green goop in your eyes? I have a kid with RSV who's not breathing. We will take care of this over the phone, right? So we all know the symptoms of pink eye. It's itchy, it's irritating, can cause photophobia. Usually they're gonna have URI. They may have a concurrent otitis with it. It's spring, thank God, not that we had that bad of a winter this year compared to last year. So a pink eye is just that, it's a pink eye. Is it bacterial? Is it allergic? Did they go swimming in the pool and they just have red eyes? So what about family history of atopy? Are they using contact lenses? I mean, I love teens. They're like my favorite population. But some of the stuff they do, it's like, dude, seriously. I know that they're long acting, but did anyone ever suggest that you just put one pair in until like the end of your life? Like, why did you not change them? Or, oh yes, I was at the mall and there was a kiosk and there was the cool one that made my eye look like a tiger, and you just go, whoa. So the differentials that we all know about, we've got listed here, can be foreign body. We've all seen kids who come in, have something blown into their eye, they've got a corneal abrasion, and they're coming in with a red eye and eye pain. So what do we know about kids with allergic conjunctivitis, right? It's that watery, red eye, lots of itching, may have a runny nose, may have eyelid swelling, may have that kind of gelatinous bulbar or conjunctiva on the side. I remember the first time I saw it, I was a relatively new PNP, and a kid had put peanut butter in his eye, and he got that immediate reaction, and I walked in the room and I thought, I am too new to handle this. I'm walking out and finding someone else because that is wrong. And he's like, oh no, this is really simple. We can put a couple drops in, and the kid was great in 10 minutes, and I was like, whoa, because it was so dramatic, right? We've seen those kids with those really dramatic, gelatinous. Parents will come in, oh my gosh, his eye's exploding, it's coming out. So we get a lot of viral conjunctivitis. If you've got rhinovirus, why are you surprised that the rhinovirus is in the eye as well? And so that's more of the tearing. You may see the preauricular lymphadenopathy. Once we get to bacterial conjunctivitis, it's more of the swelling on the front of the eye, and you get that nice, nasty, boogery drainage that you walk in the room and you go, I know why you're here, because it's just dripping out of their eyes. And if you do cultures, most kids are going to grow back either H, flu, or strep pneumo. You don't need to do cultures, however, routinely, except for neonates. And I had a very wise woman tell me once, and we're not talking about zebras today, but you know, this could be iritis. This could be something more severe. Visual acuity is the vital sign of the eye. If you've got a kid with an eye that looks god-awful, check their vision. Because if they've got an iritis or if they have a keratitis, they're likely going to have vision changes. You've got that kid that comes in and that one eye is just nasty red. And you check their vision and they've got normal vision in their non-affected eye. In the affected eye, they have poor vision and they've never had poor vision. Well, that's kind of a really simple, easy way to say you need an ophthalmologist. Drop, punt, right? So how do we manage seasonal conjunctivitis? You can do the OTC mast cell inhibitors or the prescription ones. And artificial tears help because it helps flush out the eye. Systemic antihistamines can help. And then don't forget the old rules, right? What is the mantra? Keep your windows closed, keep the AC on, try to avoid during high pollen times. I've raised 2 children. Stop and think for a moment. You've had this 3-foot-tall person in your house for 3 months, and the weather is now good, and you say, keep them inside. And of course, they're going to let that little wild person out of their house to run around like the little crazy guy that they are. And they should. But what I can do is say, look, on the days that you go out, that you're doing soccer camp and all this other stuff, you're going to be more symptomatic. And when you come in, use artificial tears, use cool compresses. Then comes the idea of nasal steroids. And when you look at the data on nasal steroids and do they help conjunctivitis, it's conflicting, which means the guidelines aren't clear about it. So some people will say, give them a little nasal steroid. If, you know, part of the reason that they keep having issues is because they have all that congestion and they're not draining their tears particularly well. That just adds to their symptoms and maybe it'll make it better. You know, in the great scheme of things, if they're old enough and they'll be compliant with it, the likelihood of significant adverse outcomes are pretty low. But it doesn't mean that that's automatically going to be an answer for anyone. With bacterial conjunctivitis, however, it only requires 2 to 7 days of treatment. You don't have to always do 7 days of treatment. If they have a concurrent ear infection, you want to give them a moxiclav, because then you're covering for your H flu in addition to your strep pneumo. And according to the guidelines, there's no advantage to using one type of eye drop over another. So you've got your old polymyxin, trimethoprim preps, erythromycin, bacitracin. If you look at the red book says moxifloxacin, okay? But again, I would ask you to stop and say, why are you treating that eye? Are you treating that eye because you're convinced it's H flu or strep pneumo, or are you treating that eye because the kid can't go back to school if you don't treat their eye, and you're pretty sure it's viral? Well, if you're pretty sure it's viral, why are you pulling out a big gun? So in my practice, I use polymyxin because it's dirt cheap. Moxifloxacin can be really expensive. Now, if you're really sure that it's a bacterial conjunctivitis, absolutely, you can go with the Red Book recommendations. But if you're really treating it because this self-limiting condition, we're treating it so that they can go back to school so that the family's not losing money with the parent out of work, then according to the guidelines, you're okay doing any of the other ones. This is me, this is not the station or its sponsor, but I've always wondered, like with erythromycin ointment in like 3-year-old kids, and I think that's because I've worked in urgent care and convenient care, because you put the ointment in their eye and then I'm stitching their forehead closed 4 hours later when they've walked into a wall. And the mom can't understand why he won't sit still. You know, and we all know that great trick with the drops. Oh, look, it's magic water. We're going to lay down and we're just going to put a drop right here, and then you open it up. Like take a moment to talk to your parents about how to use eye drops, because parents come in and they're like, it's not getting in, and my husband was sitting on his head and I had his arms, and we had a German army come in and he's screaming and he's crying. Well, of course it's not getting out at that point. Of course it's not going into their eye. But if you just shoot the drop at the corner of their eye with their eyes closed, and then it opens up, they tend to do much better than if you're trying to pry their eyelid open. I mean, you pry my eyelid open, it's probably not gonna go well either. Newborn conjunctivitis. So the Red Book says that just the fact that you put erythromycin in their eyes, for the families that allow you to do that, does not prevent all of your chlamydia cases. So it in and of itself does not prevent chlamydia from being in your differential. You need to have a culture. But what's important to note is all those PCR tests that we run, none of them are FDA approved for use in newborns. So we're all going off label when we do that. Okay? Also, the nasopharyngeal swabs are not FDA approved for use in infants, in newborns. So if you have a kid that has severe symptoms, if they didn't get that newborn prophylaxis, those are the kids that need admission for systemic antibiotics to be treated for gonorrhea, which is rare. But what's the big issue with using erythromycin in a newborn? It increases the risk for pyloric stenosis. So yes, you don't want them to have long-term vision problems, but you're putting a newborn on erythromycin. If they turn into a puker at 3 to 4 weeks of age, in the back of your head, you say, whoa, that kid had systemic erythromycin. Another nice note, all topical eye drops for the treatment of conjunctivitis are off-label for newborns. So again, GC and chlamydia are relatively rare, only about 1 to 2%, but they have significant long-term implications. So you want to cover in the newborn for H. flu and E. coli, and I've listed some of the medicines that you can use here. So this is that classic walk in the room, yep, I know why you're here. So how do we want to treat this one? Let's go back. Still didn't work. So this is where you can do a polymyxin, and typically what I'll do is, because it's 2 to 7 days, I'll tell the parents, go ahead and treat it until you go like, why are we still putting these drops in their eye? Their eye is fine. Finish out that day, do 1 additional day. Make sure you stop by 7 days. If you still need treatment at 7 days, then I need you to come back in, because I do see iritis, I do see keratitis, it's relatively rare, but these are kids that just look like a really bad pink eye, and they've been on moxifloxacin or whatever for a couple of days, and they're coming in and their eye's not getting better, and they're having a lot of pain, and you don't want to miss those zebras. So for patient education, I've given you a couple of websites, and specifically to the guideline and the statement about school exclusion, so that when you call up KinderCare and say, well, yes, of course, you can go back because we've started treatment, that you've got the guideline in hand. Again, artificial tears, make sure that you're using good infection control for an older kid, that they have a separate face towel. Try, it's not gonna happen, but you can try to keep them from putting their finger up their nose and then touching their eyes. And good contact lens care. I see that a lot with teens. I don't know if your teens are any better about their contact lenses than mine. So the other main reason why people come in is cough, right? He is just coughing all the time. And you go, well, is his sleep disturbed? And you hear this whole story and you go, is your sleep disturbed or is his sleep disturbed? Because if he's keeping you up at night, you are as likely to bring him in as if he's sleeping through the night. And then we do all of the questions that we always do. So is he coughing really bad at night when he first gets up in the morning? During the day he's kind of and then he goes on, or is he coughing, gagging? What's going on? Because the problem is how do you differentiate the kid who has an upper respiratory tract infection from one who has a more, potentially life-threatening condition? I'm gonna focus in on these 4 today. So you have baby Smith, who's a healthy 7-month-old with a history of URI symptoms for 5 days. His cough is getting worse. He has a temp of 101.5. Yes, I'm old. I still use Fahrenheit. Respiratory rate is 36, pulse 110, SATs are 97. Intake's good, no distress. He's wheezing and has copious, clear, thick, runny nose. What's your best response? Ready? Go. So correct answer is actually D. Let's talk about bronchiolitis. It's a diagnosis for kids under the age of 2. It causes that I hate RSV. Don't we all just hate RSV? See that kid in your office at 3 o'clock, he's like, oh, he's happy, he's fine, he's got boogers coming out of his nose, life's great. 6 hours later, he's like practically needs to be intubated, and the mom's like, well, you just saw him 6 hours ago, and you're like, but it's RSV, and it changes so fast, and nothing we do really helps these kids. So when we're talking about infection, the reality is with bronchiolitis, about 1/3 of kids are infected with more than one organism. So the clinical practice guideline says no routine RSV testing. Because really, if it's RSV versus adeno versus metapneumovirus, does it make any difference? Are we going to treat it any differently? I'm not talking about those of you who work in a hospital and have to figure out who you can bunk them up with for the next couple of days. But out in the community, how critical, and the guidelines say you don't have to routinely do RSV testing. The other thing that they say is that you don't want to do routine chest x-rays on these kids because you're going to overdiagnose pneumonia. And when you diagnose pneumonia, what are you going to do? You're going to put them on antibiotics, but it's a viral condition. So they say no routine chest x-ray usage. So you see that kid, they're happy, they're fine, they're not 7 weeks old. They look like they've got RSV, they cough like they have RSV. We all hear them coming down the hall. And you hear them when they go in the room, and you hear them when you walk in the room, and you're like, oh, this kid has RSV, I can tell right now. We don't have to send them for a chest x-ray automatically. Bronchodilators, epinephrine, corticosteroids, and chest physiotherapy should not be used. The evidence is overwhelming that they don't work, and the guidelines clearly state we're not supposed to be doing albuterol trials in the office. You don't routinely give them an albuterol neb to see if they get better. Now, if they're a previous wheezer, if they have a strong history of atopy, cradle cap kid, eczema kid, they're wheezing, but your average, no reason to believe that they're a chronic wheezer, you don't do an albuterol trial, and you certainly don't universally send them home on albuterol nebs. And that's why we hate this disease, right? Because you go, yeah, your kid's sick. Yeah, this can get ugly. No, I got nothing. I can't do a test. I can't give you a neb. We're going to watch them. And mom's like, great, this is awesome. Because we know that these don't routinely work. Hypertonic saline nebs are not supposed to be used in non-hospitalized patients. That means offices, ERs, urgent cares. If they're hospitalized, yes, the guidelines say if they're not, you're not supposed to use them. And no antibiotics unless there's clear evidence of bacterial infection, and half of all kids with bronchiolitis have a bad ear, right? This winter, they've all been right ears with bronchiolitis. I don't know what it is that this year's bugs have caused just the right ear to become angry and inflamed, but they have in my world. Suctioning. Oh my gosh, and we're not talking about that nice little bulb syringe. Like get in there and it's like, oh my gosh, this kid had like a gallon of snot in the back of their head. And you really clean them out really, really well, that can do so much good. In fact, when you send them to the ER and they actually had that great wall suction, they'll suck them out and the kid be like up and happy and great and their SATs are fine and they're able to go home. Humidity can help, but doesn't routinely help. So what do? Good hand hygiene. Alcohol is a secondary option for them. You want to talk again about the secondary smoke exposure, again, breastfeeding. Kids with bronchiolitis are going to shed virus for 1 to 2 weeks, which comes back to the question, how long are they contagious? And you get to do, I don't know. I can tell you that they shed virus for 1 to 2 weeks, but the kid's happy, eating okay, acting okay, isn't so sick that they need to go home, they can often go back. And we need to tell parents why they don't get antibiotics. Because it is my opinion that in this country, when kids are really sick, there is the expectation that it comes with a prescription for something stronger than amoxicillin. So if you're saying, yes, your kid is sick, yeah, they may get worse, they need to know why no antibiotics. Bronchitis is another one of those diagnoses. It lasts for 3 weeks. 90% of cases are caused by viruses. So what does that mean? If you know that 90% of your cases of bronchitis are caused by a virus, what do we not want to give them? Antibiotics. And isn't that the excuse that a lot of us use to give antibiotics to an older kid with a cough? So no antibiotics, and the exception to that is pertussis, and they need a macrolide. You shouldn't routinely be giving them expectorants. And antitussives need to be used really thoughtfully in kids after 6 years of age. I don't like coughing. Nobody likes coughing. Anybody in here enjoy being up all night coughing? But what do we know about dextromethorphan? Behavior change, pseudo-psychotic episodes, nightmares, night terrors, bad outcomes, bizarre behaviors. And does it actually ever stop anyone from coughing? I ask parents all the time. I'm like, well, he's been on this, and this. And I'm like, is it working? They're like, no. And I'll say, have you ever taken a cough or cold medicine and got better any quicker? And they go, well, no. So why do we do it? Why are we recommending it? There is conflicting data about beta-2 agonists and steroids. And so I think that's where a lot of us, especially with the older teens, will try like an albuterol trial in the office. There is evidence for dark honey, increased fluids, rest, humidification, and then education and why we're not treating them with antibiotics. Because bronchitis is one of those diagnoses that people use to justify antibiotics, especially in adults. And if it's viral, why are we doing that? Croup, we all know the Croupers, right? So this is the real Croup kid. This is not the kid that has the loogies sitting on their voice box that sounds a little rough. That harsh, barky cough, it's primarily caused by paraflu. And what we know is a single dose of oral Dex or nebulized budesonide can work. A single dose, not 5 days, a single dose. And that there is some evidence that prednisolone can be used as an alternative to dexamethasone. You know those vaporizers and sit on the floor with the shower running and steam? There's no evidence that that helps. Now, is that a particularly bad thing to do? Probably not. You're giving the parent something to do to go sit on the porch at night. If they have severe illness, so they're tachypnic, they're having difficulty breathing, having persistence of symptoms, those are the kids that may need to be hospitalized. And then again, what are we going to tell them? These are the signs that if they happen, please call 911. Please take your kid to the emergency room. These are the signs that we're worried about. And then Tylenol and ibuprofen for pain. So Jane comes in. She's got a 7-day history of nasal congestion, cough at night when she first wakes up. She's facial pressure and a complaint of headache and sore throat. What does Jane need? Jane, yay, you guys are brilliant. See, you didn't need me. Jane has a cold. So here's don't you love that? Oh yeah, oh my gosh, I felt so bad and I took 1 dose of amoxicillin, my sinus infection went away. Congratulations, you had rhinovirus. It doesn't work like that. So what are the diagnostic criteria? You have nasal discharge with daytime cough with no improvement for 10 days. So when they start to go, well, yeah, it was really bad on Thursday, Friday, Saturday. By Monday, he was doing better. He's a little better yesterday, but he was up last night. He's gotten better. So it's no improvement in 10 days. or they have a sudden worsening with new onset of nasal discharge, fever after initial improvement, or very, very severe symptoms with high fever. Remember that these little ones, these cute little Huggies-wearing children, don't have frontal sinuses as a cause of pathology. They have green snot because they don't blow their nose, because it's been sitting in there since last night. The key to diagnosis is that symptom persistence. I don't know why there's a question there. Okay. So what do? It's really difficult to distinguish if you've got a URI versus a sinusitis, except for under those conditions. You should not be routinely scanning heads to determine if they have a sinus infection. Antibiotics should be reserved for severe or worsening disease, for those with symptoms for more than 10 days, and it's the same antibiotics as otitis, but you can do the lower dose of amoxicillin if they haven't had antibiotics within 4 weeks, they don't go to daycare, and you don't have high resistance in the community, which means virtually nowhere in the United States right now. A 10-day course is appropriate, and you want to have them follow up if they're not better within a few days. That saline nose spray doesn't work. That nasal irrigator that, we all kind of go, ugh, but that works. But you want to use distilled water, or you want to use commercially made saline. You don't want to use tap water with it. When you're using tap water and you're doing the saline irrigation, you can cause all kinds of problems. You don't want to do oral or topical antihistamines, oral or topical decongestants. You don't want to do mucolytics. Okay? I know you're all familiar with the URI. The take-home message on URI management is we don't give cough and cold medicines to kids under the age of 6. We do know that agave and honey syrup can help before they go to bed. You can give the agave to kids under 12 months of age. You can't do the honey under 12 months of age. Gargles. How many of you like gargling with salt water? It's disgusting. Why are we shocked that our 5-year-old children don't do it? Yes, it may be better than gargling with warm water, but children will gargle and spit on command for fun. So let them do it with just warm water and get that phlegm off the back of their throat before they go and they lie down. Topical decongestants like neosynephrine, Afrin can be used in older kids and can be very effective. You want to make sure that you limit them to 3 days so that they don't develop rhinitis medicamentosa. Can take 3 weeks to get over a cold, right? Nobody likes it. I don't like it. I had one that started the first week of January. I was still blowing my nose February 1st. I was mad. But it was a cold, and I didn't need antibiotics, and I didn't need to take the risk by having that prescription. And our last discussion for today is abdominal pain, and we've just got 2 minutes and 0 seconds as of right now. So this is a tough one, and it was an absolute talk unto itself here this time. Kids come in with stomach aches all the time, right? Postnasal drip, they can have gastroenteritis, they could have eaten a silly straw full of sugar, it could be just 'cause. So, and then there's the gas. I mean, how many of you guys have had teenagers come in that look like they had appendicitis because they were doubled over and they just needed to pass gas, but they'd never experienced constipation or gas before, and they were pretty convinced that it was a life-threatening condition, and it is pretty uncomfortable. The problem is distinguishing. So you'll see here that the starred symptoms that I have here are those classic pathognomonic signs for appendicitis. These are the ones that we worry about. When you have these physical exam findings, these are the ones that should be raising suspicion. What we get a lot of is that recurrent abdominal pain, right? That kid that just has tummy aches all the time. And it's a leading cause of referral to gastroenterology. So these are kids who are usually school age to adolescent. It's that periumbilical pain. They complain of pain after they eat or abdominal discomfort. It may hurt when they go to the bathroom. They may vomit on occasion. They'll eat a little bit. They feel really full. But if they have a bowel movement, they feel better. And so really what we're doing for these kids is, number one, we're not making a federal production number out of it. We're not working them up to an excessive amount. We're going to ask them what makes it better, what makes it worse, talk about their BM qualities. Teenagers are like, oh my gosh, you asked me about my poop. Like, oh my gosh. Yeah, I poop too. And that's often how I put it. I pooped this morning, actually, so we can talk about poop because everybody poops. And it's okay. We all poop. Some of us are better at it than others. So let's talk about it. What does it look like? How often is it coming? Does it hurt when it comes out? All those questions that we're used to asking. And what you really want to look for are these red flags. Any of these red flags are signs of those zebras that we're not looking for today. And these are the kids that need to go out. So what are we going to do? We're going to determine that this kid maybe is getting a ridiculous amount of caffeine and they're getting cramping because of their caffeine. Or maybe they have a food allergy or a food intolerance, that we can modify their diet and improve their symptoms. Teaching kids good toilet habits. Many of us don't have good toilet habits. You're sitting there, you're like, whoa, gotta go to the bathroom. Well, I can't do that right now. I'm at work, or I'm here, or I'm there. Like, if you gotta go, you gotta go. Everybody poops, it's okay. Nowadays, they've got little Febrezes you can carry in your purse. You can be making the public bathroom smell like an orange. It's all right. Well, everybody will live. Nobody knows who you are, what you're doing in the stall. It's okay. But if they're really stressed or they're really anxious about it, psychotherapy can be really, really helpful, because think about what that stress and anxiety does to their perception of their abdominal pain. Thank you for coming today. So I don't know that we have time for questions. I think it's time for you to go on to your next life. Oh yes, please don't leave with your keypads.